Good morning, everyone, or whatever time zone you're in. Good afternoon for some, good evening as usual. As chair of the study, well, first of all, I'm Guy Palmer. I serve as chair of this study and of this committee meeting. I'd like to welcome everyone. The task being undertaken by this committee of the National Academies of Science, Engineering, and Medicine is to examine the long-term medical and economic impacts of increasing antimicrobial resistance in the United States. The task being undertaken by this committee of the National Academies includes commenting on the progress against the national strategy of combating antimicrobial resistance. The full task is described on the study website. I want to note that this is an open on-the-record session. Interested individuals and members of the press have been invited to attend as observers. This is not a news conference, however, and we will not be entertaining questions from the floor. Reporters who would like to speak with committee members are kindly asked to touch base with the study director, Jillian Buckley, and her contact information is on the study website. I want to remind everyone this is an information gathering session. That is, the committee is in the process of assembling materials that it will examine and discuss in the course of making its findings, conclusions, and recommendations. Therefore, I ask that everyone be mindful of the fact that the committee has made no conclusions and that it would be a mistake for anyone to leave here thinking otherwise. Comments made by individuals, including committee members, should not be interpreted as positions of the committee or of the National Academies. In addition, committee members frequently ask questions, probing questions in these information gathering sessions that may not be indicative of their personal views. The committee will deliberate thoroughly before writing its draft report. Moreover, once its draft report is written, it must go through rigorous review by experts who are anonymous to the committee, and the committee must then respond to that review with appropriate revisions that adequately satisfy the National Academy's Report Review Committee and the National Academy of Sciences president before it is considered an official National Academy's report. I think with that as our preamble, I think we are ready to go ahead and get started. Just 1 second here. I've got to switch.
Are you ready to go, Dr. Balser?
I think we're ready. I think we're ready to go. If Manika is.
Yep, I'm here.
Oh, super. Yes, go ahead and while I introduce you, you're the executive director of the GARDP, and we're delighted to have you and Jennifer here as well this morning to speak with us.
Great. So thank you very much to the National Academies for inviting me here today. I'm just going to share a very quick presentation, and then obviously we can go into some questions. And what I'll try to do here is really give a flavor of what a non-profit approach looks like in terms of developing, accelerating the development of new antimicrobials. But first, just to start with an example of our organization, we are an organization that was really conceived in 2016 and then was set up as a legal entity in 2019. So we are very young and very new. And we've actually been operational now for about 3 or 4 years, as you will see. Our organization's mission is to ensure that or work towards where all infections are treatable for everyone, everywhere. And obviously this means that our focus is really on trying to address the growing problem of drug-resistant infections. Our mission really is to bring together the public and private sectors to develop new treatments for bacterial infections, but also to ensure responsible and sustainable access to these new treatments, thereby addressing the public health impact of antibiotic resistance. And so there, I think it's an important differentiator for us. Our mission is really the next step beyond just developing a drug and getting it registered in the FDA or other countries. We're really looking to take the next step and see how we can work with our partners to ensure that these antibiotics can be introduced successfully where they're needed. Our focus is on the WHO World Health Organization priority pathogen list, but we don't just look at bugs. We are also looking at what infections and disease syndromes we can address that are of public health importance, as well as what populations that are high burdened by antimicrobial resistance, but also underserved. And obviously our approach is really working through partnerships. So we're not a standalone research organizations doing our research in isolation. Our approach is really to work through a network of partners, both in the public and private sector. Now, I don't need to tell you why an organization like us needs to exist, because clearly we're really dealing with a broken market. Antibiotics are an area with high public health return, but very little commercial return. And I think you all have been well briefed by previous sessions on why this is the case. But what does this mean in terms of a not-profit model? I thought I'll probably just in one slide really go into some detail on what we do and why. And this can apply to other non-profits. It doesn't apply to just our organization. But we try to address several issues. First, how can we meet global public health needs? How can we best use public money? Because that's very much the origin of a lot of our financing. How can we ensure availability and appropriate use, particularly of new antimicrobials? How can we ensure equity and meet specific challenges, particularly where there's a high burden of disease? How can we address emerging threats? And we have to recognize that emerging threats may be happening in different parts of the world, often where things are unmonitored or where there's very little access to new antimicrobials. And particularly, how can we look at infrastructure for global R&D projects? And so based on that, we've really developed a range of different interventions, starting at the very top, about really developing an objective and long-term approach on developing a public health portfolio. And this is a portfolio that we expect to evolve over space and time. So it may differ for different geographies, and it will certainly differ, change and evolve over time. And we build this portfolio really to target public-private partnerships. And it's important to understand we don't work through a set model of a cookie cutter approach of saying, okay, this is how our partnership works with a private sector entity. We really tailor our approach based on that individual company, what their asset is, what are their capabilities, who are their other backers and supporters, and where are their gaps and what are their needs. So, and we then marry that with what we try to see as our kind of public health objectives. And so every public-private partnership we have is different. We also look at exploring and investing in high-risk projects, and I will give examples of that later, but also look at going beyond just the kind of regulatory pathway. How can we obtain additional data to get approval for key indications, generate more real-world data? And this also includes doing research and development in populations where there's a high burden, but also where there's a high need. So neonates, for example, we see a very high burden and very high mortality or in the neonatal population from antimicrobial resistance, but actually very few research efforts going into developing new treatments. We, of course, develop and conduct R&D in different geographies, particularly low middle income countries, and work to not just do the research, but expand access through strategies around licensing, registration, improving treatment guidelines at country level, supporting stewardship and supply. And obviously work towards setting up and support global networks and collaborations. Through that, we hope to ensure new treatments are available long-term, deliver most needed treatments, work around stewardship of these new antibiotics, address underserved needs such as neonatal sepsis, addressing also accelerating also access to high burden areas. And we have to remember that many of the new antibiotics that are developed are only available in a very small handful of countries, but also through that developing and building trial networks that can be available for all actors and not just us. And obviously there's reasons why as a not-for-profit we will be doing this. So obviously as a not-for-profit we can take a long-term approach. We don't have the commercial imperative. That may allow us to take more risks, invest in areas with low commercial return, but high public health return, and really address challenges that will not be taken up by others, and really also take not just a local, but also a multilateral approach. So we can really bring countries together, different funders together in projects as well. So what do we do as an organization? We really work on 4 thematics. We work in serious bacterial infections and in hospitalized adults, drug-resistant infections in neonates, and also in children, and sexually transmitted infections. And we're really focusing on late-stage clinical development and early access of these treatments. And in our current business plan going from 2020 to 25, we've estimated a need of around 500 million to at least aim of delivering or accelerating the delivery of 5 new treatments, looking at both repurposing of old drugs and accelerating the development of new drugs in the pipeline. So this just gives a flavor. This slide is not to scale, but this just gives a flavor of where our focus is in comparison to other actors in the field. And obviously we have a very strong bias towards clinical development and access, but it's also an area that is, I think, relatively underserved considering the needs. Now, I won't go through the slide, but this is really kind of our achievements to date, but I thought I'd bring out a few of the kind of partnerships that we have built in our kind of non-profit approach. We've actually partnered with 2 US biotech companies, Venatorix Pharmaceuticals and Entasis Therapeutics, to really accelerate the clinical development of 2 drugs, one for sexually transmitted infections, another for serious bacterial infections, in this case being developed for complicated urinary tract infections. And both projects are ongoing. They're both in phase 3, but we've developed 2 very different partnerships here. In one partnership, we are actually the sponsor and leading the clinical phase 3 clinical trial that is currently ongoing in several countries, including the US. And the other partnerships, we're really supporting the company who are sponsoring a global clinical phase 3 trial, but really preparing the ground for continuing additional studies beyond phase 3, including pediatric development. We've conducted also one of the largest neonatal studies involving over 3,000 babies. It's really a study that really probably would not have been done by many other actors. We did this with a group of partners. The study is now completed. It's really given us a huge amount of information to go to our next stage, where we're now developing an empiric treatment study for neonates. That's also on the back of conducting additional R&D on a drug called fosfomycin, but we're also looking at doing additional work on other drugs, including a drug that we're now partnering with a biotech company. And so we are planning to conduct both pediatric and neonatal studies, as well as empiric studies to really guide future treatments for both neonates and children. We have additional work that's going on both at early stage, but this is relatively small. But really here we are working with a consortium of Japanese companies, for example. And additionally, we have a kind of transversal education program where that really works through a series of conferences, webinars, and information that we share online as well. So that gives you a flavor of the kind of work as a non-profit that we can do and that we've done and set up over a relatively short period of time. Just to wind up this presentation, I just thought I would add that one of the important aspects of our work is to really look at the next step. What happens when a drug is registered, and how can we look at really delivering sustainable access? And it's important to understand that for us, access means looking at multiple different aspects: affordability for the health systems, its appropriateness, how can it be supplied in a timely manner, how can we also look at stewardship and responsible use. And so really based on that, we've developed an access framework and really involving multiple different interventions. As an organization, we can license, we in and out license compounds, and that really allows us to conduct certain activities to really support access. We can work on regulatory aspects, particularly in lieu with not just our private sector partners, but also with other actors, including the World Health Organization and national regulators. And that can really work on what additional public health evidence needs to be generated, label extension, and really looking at registration in a wider range of countries. And here we're exploring the use of collaborative regulatory processes to help this. We're working on public health policy and use. So how can we really look at adapting guidelines around the world, but also in terms of professional societies. Outsourcing strategies here, really looking at improving CMC manufacturing, cost of goods. So in one of our phase 3 projects, we're really focusing and investing heavily on this. But we're also working on other aspects such as procurement and reimbursement as well. Now, it's important to understand that we don't do everything in all of these different aspects for all our projects. Sometimes we'd be advocating, sometimes we'd be facilitating, but sometimes we'd actually be hands-on implementing in these kind of different buckets of work. And just like to finish by saying that in part of the work we're doing around access, we're developing a project called Secure, and that's really about how we can bring what we call reserve antibiotics to patients, but really look at how we can adapt them to clinical needs as well. And the different pieces of work that I've already highlighted in the previous work slide, ranging from regulatory to evidence generation, to adapting guidelines and supporting real world use, as well as looking at procurement mechanisms and pricing mechanisms that can really help to bring these new drugs to a range of different countries. And we're really working with some partners on this project. So I'd like to thank you for your attention, and really just to make a point to say that there are many different ways and forms of nonprofit models. I've just given you an example of what one may look like. In terms of how we work, we've got funding from a range of different partners, largely countries, I would say. To date, GARDP has probably raised around 110 million US dollars, and we are actively continuing to raise financing for our current business plan. And it's important to also understand that our money is not done in isolation. We really bring money with other partners who bring money. And I think what we do is we try and leverage financing from not just us, but other partners who may be involved with some of the partners that we're working in, for instance, with a biotech company. We may be bringing in resources, but so may other partners like BARDA. And so what we try to do is really leverage what they can do, what we can do to really accelerate drug development, but also then look at the point beyond the research and looking at access. So I'll stop there, and I'll be happy to take some questions from the panel.
I have a quick question.
Yeah.
Sorry, Dr. Balasegram, can you go back to that slide where it had the timeline of the activities from like exploratory, preclinical, clinical trial?
Is it this one here?
That's the one. So
Yeah,
is that GARDP's involvement? Are those white lines supposed to show like the relative involvement? So a lot of clinical development.
Yeah. So that's what GARDP does. And I just want to emphasize, this is not to scale. So it's just to show what GARDP's role is, and then what we other actors are doing. And on the very kind of top horizontal bar, you can see that our focus is really around clinical development and access. And that's a choice. We do some discovery exploratory work, but there are other actors like Carbex who are doing an excellent job in this space. Here we've really tended to really take on projects and work with partners or consortiums, like for instance, a consortium with Japanese companies that are really something where we can have a value add. While in the clinical development space and access space, this is something where we really focus our time, effort, and resources, and we're really working hands-on, for instance, with biotech companies to accelerate the development of new compounds, but really think about how we want to look at global access of these compounds as well, which I think is a major challenge.
Thank you. That's all.
Okay, I'm scanning for other questions, which is a little tricky. So go ahead, anybody who has a question, go ahead and Andy, I can see you unmuted. Okay. So
all right, I'll go ahead. Thank you very much. Always interesting to hear about these exciting developments. But I have a question. I wonder if there's any analogies to be learned and applied in terms of bringing, for example, new antimalarials to use as needed, given that in that particular instance, there's an obvious concern about resistance to what we currently have available. And in particular, in the access area, there's also a dimension of approval that is at the country level. And so that just brings up the question of have you all been thinking about how to navigate not just the regulatory, but the guidelines, not just at the national or the international level, but also the local level as well. Thank you very much. Over.
Yeah, very much so. And in a way, our philosophy is, we want to bring some of these really important technologies that are, for instance, being developed by US biotech companies that we're partnering with to the world. And that, I think, helps everybody. But we have to obviously do it in a responsible fashion. We have to look at some of the regulatory challenges because we have to be involved and even hands-on involved in supporting the expansion of registration in different countries. As I mentioned before, some of the kind of R&D work goes beyond phase 3. So how do we generate additional evidence for guidelines, not just kind of global guidelines and professional society guidelines, but national guidelines, because these often drive procurement policies and it's often what generates demand, but also it's what supports stewardship at country level. And this is often a very overlooked area. And particularly when we have to then compare this to other drugs in development, other drugs that have recently been developed, here we may have to bring a range of different companies together and work with different companies in doing this. So this may require some comparative studies in the future. But I think it just gives you a flavor of why a non-profit approach is important, because you often need a kind of neutral player to come in and do this kind of work and accelerate this. And as you can clearly see, there may be very little or no commercial imperative. It's very hard for a company to actually justify doing this to their internal management. And many of the companies we are partnering with are relatively small. It'll be a challenge to register in the US alone, let alone another territory like the European Medicines Agencies. But in a way, if we don't do this at a global level, we're not going to achieve the critical mass required, I think, for these antibiotics. And that goes back, I think, to some of the discussions you may have had about incentives. Very important that we have incentives for antimicrobials, but we also need to think about the global dimension and getting a critical mass for these antibiotics as well, but obviously ensure that these antibiotics are used responsibly as well. And not to forget, at some point these drugs go off patent and how they're then subsequently used can be quite complex and obviously create more pressure on that drug. So it's important we try to do this work as early as possible that help guide use of these drugs, and therefore continue that beyond the patent life of that drug, because the lifespan of these drugs will go beyond the patent life, obviously.
Okay, other questions from the committee? Go ahead and just, the easiest way for me to do it is if you just put your video up, Lefteris, I can see you. Go ahead, Lefteris.
Thank you, Guy. This was excellent. Thank you very much. A question that I actually have two questions, if you could take both. The first one is, when a large company abandons the antibiotic drug discovery arena, or a small company, unfortunately, goes, stops, goes under, all this information gets lost because they move away, and all this drug discovery, all these, successes and failures, screens that were done, all those are not deposited somewhere. They are left to other scientists trying to repeat the same endeavors, sometimes with the same waste of resources. To me, it sounds like this would be a nice platform to try and bring together this existing information when a company does not need it anymore. So where all drug discovery in general becomes a little less expensive for everybody. I don't know if I was able to to convey my thought in a way that is understandable, but I was wondering if that is feasible. And please let me know if this is understandable. Thank you.
Yeah, no, the question is very clear, and obviously there are some things we have to balance out. I mean, on the one hand, you know, I think we have to be very careful not to put companies under more pressure, particularly ones that are extremely vulnerable. And you know, I think there's you know, one doesn't want to be kind of, we say in English the expression, a carpetbagger or an opportunist that just picks up asset from companies that have the misfortune of you know, going through you know, a bankruptcy or whatever for the reasons that you've all heard of in terms of the market failure in the space. But indeed, you know, it is of course something that we have considered, that there may be situations where we could harbor an asset, and that's perfectly possible. The fact that we're able to we are actually even licensing assets from companies shows that we can do this, and this is our modus operandi. And we can even also do this and consider this for some old drugs that may become off patent and therefore may have very little commercial interest, and maybe efforts that have been abandoned and for some reason could be picked up again, but again, there may be no or little commercial interest. And here we would look to really build a consortium of partners to then work on a drug development project. It could be a for-profit partner, actually. If they see there's significant de-risking of investment, there could be a reason why they may get involved, ranging from corporate social responsibility to more strategic corporate reasons. Or we could take a non-profit approach. That's also possible. This has been done in other therapeutic areas. We know, for instance, in the field of neglected tropical diseases, this has been the case. So that is perfectly possible. But we do have to remember that antimicrobial resistance is a very big area. It's not like malaria, where you have, you know, a couple of parasites that are really important, a couple of species of parasites are really important, and a clinical syndrome, and you can develop drugs that can target that. We're talking about multiple different pathogens, multiple different ways this can present, affecting multiple different populations or subpopulations all across the world. And this is why our philosophy in GARDP is that we really believe that no sector can do this alone. We need, you know, to mobilize the private sector behind this, but we also need the public sector to mobilize itself. But we also need, this is also a reason why we believe there's an important space for the non-profit approach as well. And so we believe the complementarity of different approaches is what is really going to achieve success in this space due to the complexities of the challenges that we face here.
Doing my scan, I didn't see another question, so I was going to jump in myself with one, jump the queue a bit. Your last point is really important. The complexity of, you know, not only the different nations, the different players in this, from supranational organizations to national organizations. This complexity, how do you see that ties together, and where do you see the biggest gaps in doing a better job of tying that together? So I'm not asking you, but maybe just from your position with GARDP, but rather from your perspective of having this role.
I think there's not an easy answer to that, and the unfortunate is, that's why I asked you. So. Yeah, but I think the key is really, in a way, why you're actually doing this, having this committee, because I think there needs to be a reflection on the fact that you probably need to think about what are the multiple different levers one needs to put in place. There's no one magic bullet solution that you need to just put in place and suddenly you're going to get drugs coming through and we're all going to live happily ever after. And anyway, we know that bacteria evolve. This is the nature of living things. And so this is going to be a long-term affair. So this is why we do think there needs to be complementary approaches being put together, both from public and private sector and non-profit sectors. Now, here's the hard bit. How do we coordinate, and how do we do that? Well, I think some of that can be done by governments in terms of national strategies that they developed. And a reflection of the national strategies can be in terms of supporting many different types of interventions. So I would strongly encourage all of you to think about that aspect, because that in a way can help to create the potential of different actors then coming together under different frameworks. I don't think all of us needs to be coordinated all of the time. And I think it's good to encourage some creativity and spontaneity coming through in terms of innovation. This is very important, of new ideas and new approaches being developed. But I do think that that is very important. And then I do think that there needs to be some coordination between countries as well. Whether we like it or not, AMI is a pandemic of sorts, that slow motion one, but one we're living through. It's getting worse every day. And this does require some coordination between actors, and particularly, I think, between governments. And we've seen that kind of coordination coming through. We've even seen that happening in the private sector, for instance, where companies are coming together now to support that. But I do think we have some ways to go on that. And certainly, some vehicles like GARDP can also be a place where we can try to bring people together and bring groups together to work on a common purpose on some of the kind of thematics that I mentioned as well.
Super, thank you. I knew there wasn't an easy answer to that when I asked it, but I really appreciate your perspective. Are there any other questions from the committee? We've got just a couple minutes left, so I'm going to do a quick scan. If you're going to jump in here, please let me know. Lefteris, I see you came back to life.
Yeah, quick question. What about the resistance outside of human illness? How do you see that? And is there a similar approach there?
No, I think that's a very good question. And, I think when we were actually set up as an entity, we gave ourselves a very broad scope in our mandate and charter. And, do include how can we support innovation in infection prevention control, and even potentially at some point beyond human health. But unfortunately, obviously, based on the resources we have, and obviously the amount of work that we can do as a new entity, this is where we're focusing. But I do think there's space to look at non-human health as well, and strongly encourage other actors to really look at different approaches that can take here. We're strong believers in encouraging other entities, and other non-profit approaches I think would be extremely beneficial here. But here again, I would encourage to really look at working on a public-private approach to really bring together different actors in this, because I think there's quite a lot to do in the kind of non-human health space as well.
Well, thank you. We're at the end of it. Tom probably could go on for some time, but really appreciate your spending time and your perspectives and your presentation this morning. So
thank you.
Really deeply appreciated. We're now going to move on to Dr. Anand Shah. Yep, good morning or good afternoon, depending where you are. And I think we can turn it over to you.
Good morning, Dr. Palmer.
Yep, good morning.
Are you able to see me okay?
I can see you perfectly, yep.
Okay,
I
great.
hear you perfectly as well, great.
Well, first off, I want to thank the National Academies, this committee, and you, Dr. Palmer, for the kind invitation to share some thoughts with you around payment and reimbursement. It was a privilege to serve at CMS and FDA over the past 4.5 years. We made a lot of progress on AMR across the health and human services agencies. Let me start off by saying that while the government has made significant strides in optimizing the economics around antimicrobial drugs, the financial incentives for prescribing antibiotics still remain malaligned under Medicare's hospital payment system. The commercial failure of Zemdry highlighted the insufficiency of Medicare payment systems and individual incentive programs. In 2019, when I was at CMS, we met with many companies with situations similar to Academies. We've consistently seen antibiotics struggle under the usual volume-based model with far less revenue for peak sales as compared with drugs for other indications. As this committee knows very well, antibiotics experience further pressure from the design of inpatient payment programs. The inpatient cost of all the services for a given diagnosis are bundled into what's known as a diagnosis-related group, or DRG. So often this leads hospitals to opt to prescribe cheaper antibiotics. This phenomena further contracts the market available to new drugs. Based on extensive stakeholder input and feedback from notice and comment rulemaking, CMS took a series of decisive actions in late 2019. So let me just recap some of those. First, in the fiscal year 2020 IPPS rule, which is the inpatient payment rule, CMS developed an alternative pathway for new technology add-on payments, or NTAPs, without the substantial clinical improvement criterion, and also increased the value of these payments from 50% to 75% for FDA designated qualified infectious disease products, or QIDP drugs. This was important because many antibiotics struggle to demonstrate substantial clinical improvement at the time of FDA approval due to the traditional non-inferiority trial design that's often deployed in the development of antibiotic drugs. This new pathway accounted for this. In that rule, CMS also adjusted severity levels for antimicrobial drug resistance within the clinically relevant DRGs. And specifically, CMS changed the severity level designation from non-CC to CC. And CC refers to with complications or comorbidity for multiple ICD-10 codes specifying AMR. And building upon this, the following year, CMS took additional steps based on continued feedback in late 2020. So in the fiscal year 2021 IPPS rule, CMS expanded NTAP to include limited population pathway for antimicrobial and antifungal drugs, or known as LPAD. These now, with this rule, were considered to be new and not substantially similar to existing technology. And like the QIDP drugs the year before, these LPAD drugs no longer needed to demonstrate substantial clinical improvement criterion, although the drugs will still need to meet cost criterion. CMS also adopted a policy based on stakeholder feedback for conditional approval of antimicrobial products that otherwise meet the NTAP alternative pathway criteria, but don't receive FDA approval in time. In other words, CMS now extended additional consideration to drugs being approved outside the calendar year rulemaking cycles at CMS. And so taken together, these policy actions represented a fairly significant realignment of financial incentives for these drugs. However, these drugs still remain buried inside of a DRG. They require administrative action by the hospital back office to seek the NTAP when these drugs are used in their patients. And stewardship still remains a key consideration. So with that being said, we need to think through additional approaches for pull incentives that maximize public health impact. One alternative approach that we thought through at CMS but has not been implemented is considering a licensing model. In such a model, hospitals would pay a licensing fee for access to a drug. And this would then in turn provide them with the right to use a certain fixed number of doses annually. I like to think of this as a model similar to software licenses, where businesses pay for a pre-specified number of installations or seats. Here, CMS could drive forward several important public health goals. First, this type of subscription model will create a natural market for drugs that meet certain public health criteria. And that could be simply these drugs or QIDP or LPAD designated products by the FDA. This would provide a more predictable return on early investment, as well as a steady revenue stream through licensing fees. Second, and importantly, it would put hospitals fully in charge of stewardship for these important medicines. And once a hospital purchases the ability to access a drug, they would then be the stewards of its use up to a fixed number of annual doses. And the doses could be allocated by Medicare based on the number of hospital beds or the prevalence of organism in the surrounding community. So there are two potential avenues to implement such a model at CMS using existing statutory authorities. First, the 1115A authority, as written in the Affordable Care Act, would allow CMS to design a time-limited model at its Innovation Center, or CMMI. Here, the statutory criteria would be whether the model decreases the cost of care, improves the quality of healthcare delivery, or both. Alternatively, Section 402 of Public Law 92603, or what we refer to more colloquially as a 402 demo, grants CMS the authority to waive Medicare payment and benefit statutes to conduct demonstrations. And these types of demonstrations or demo models may be stood up by CMS leadership or also be initiated as a result of congressional mandate. But there's several considerations that would need to be worked through, including whether there is multi-payer participation. CMS really can't be the only agency financing such a model. And as everyone here knows, Medicare represents only a subset of Americans. For example, Medicare would be buying the doses in such a model, but it's difficult to conceive how these doses would only be used by Medicare beneficiaries at the point of care. Second, we need to think through the extent of global participation by health authorities, since AMR is very much a global concern. I would say third, demonstration models are, at their very essence, time-limited experiments. You have to have a comparator group, perhaps in such a model that could be fee-for-service patients outside the model who are still receiving these drugs under conventional DRGs. We need to think through how cost and quality are measured as part of such a model or demonstration project. Can we use existing measures, or do we need to establish new validated measures for quality for such a model? We also need to think through how we demonstrate savings to Medicare. Is it some function of avoided hospitalizations, ER visits, or avoided medical procedures? And lastly, even if the model, if conducted successfully, meets the statutory criteria for expansion at the end of the demonstration period, we need to think through how this would be rolled out more broadly outside of the demonstration or model framework. So in other words, how do you get this type of program out nationally? We've seen similar models. Many of you may be familiar with the model recently launched in Louisiana for hepatitis C drugs, whereby the state Medicaid program partnered with a subsidiary of Gilead to provide novel hepatitis C medications there to its citizens. And so this type of model has been performed, albeit on a smaller scale, so we need to think through what a national program would look like. But those are my comments for today. I want to thank you for your time, and I'm happy to take questions from the committee.
Yeah, thank you very much. That is super helpful. And again, for members of the committee, the easiest way for me to call on you is just for you to turn your video back on, then I can see you almost immediately and call on you. So Lefteris, I see your video.
Yeah, Anand, thank you very much. This was very nice and very helpful. I have a specific problem that I'm on clinical service, so I have a very specific thought in mind. I'll try to present in a more generic way. But what pains me is when I see somebody who is colonized with a resistant pathogen for quite some time. and then comes in with a very bad infection, endocarditis, osteomyelitis, very severe infection that will require a lot of antibiotic management, and that person never was offered decolonization. Is there any way that this can be incentivized in a better way? It's cost effective overall, but why this doesn't work? This is outside of specific big drugs. It's very mundane. Decolonization is a mundane, but a very cost-effective approach against anti-resistant pathogens. Thank you.
Yeah, thanks for your question. And I just had a follow-up question for you. And so just, kind of going through that patient example there, where do you see the bottleneck in terms of, or the misalignment between management and kind of where the financial incentives currently are?
All hospitals screen patients for a few resistant pathogens for isolation, infection prevention. So the recognition is there. But, and the studies for cost effectiveness, the last study was in New England Journal of Medicine. There are well-established studies that prove that it's a cost-effective approach. The problem is that there is fragmentation. So there is, in my opinion, and this is just my trying to wrap my head around it, my mind around it, but it's fragmentation of care. There is no effort. People care sometimes is episodic. So we care only for what is going to happen now. We don't think long term. Even insurance agencies think about an individual for a year at a time, most of the times. Hospitals see a single hospitalization episode. So there is no interest to do the decolonization, do the screening, etc. So this is my thought, but how can this be incentivized? Because overall it will save a lot of money and a lot of morbidity and mortality and a lot of escalation of resistance. Thank you.
Yeah, thanks again, and thanks for the clarification. I agree. Having some sort of mechanism for screening or colonization, I think would be prudent, right? And especially in the inpatient setting, for these patients, I think what payers will really need to think through, and especially CMS, is there some sort of gating mechanism that can be implemented to further subselect patients who would receive additional screening? Is there a risk stratification? But really, the payers are going to look primarily to the clinical practice guidelines, right? And if the clinical practice guidelines, support a widespread intervention for either a subset of patients or even more broadly, there, I think it's a compelling use case, to payers, then to put in place the appropriate incentives, that would steer clinical management.
Thank you.
Okay, other questions from the committee? You can put it in the chat, or you can just put your video on and I can call on you from that. So I've got one that you kind of alluded to, and it's a little more broad, but it's something you've addressed when you're looking at cost effectiveness, and that is basically the concept of avoided medical procedures, which is a really tricky thing to measure, but it's obviously implicit in almost any kind of preventative medicine, including appropriate use of antibiotics. Can you comment on what has been successful in terms of studies that have looked at that, approaches to look at the overall idea of an avoided medical procedure, or a shortened hospital stays are probably a little bit easier because there's something there to measure. Complete avoidance it really gets tricky, but any perspectives you have on that would be helpful.
Yeah, Dr. Palmer, I mean, I think it is tricky, to make that measurement, right? And how do you, especially when it's a avoided medical procedure, that's one of the reasons why these, whether it's a CMMI or Innovation Center model at CMS, or it's a 402 demonstration, fundamentally they are set up as experiments. And so I guess the other way to look at it would be absent an intervention, in this case, patients who are receiving these drugs outside of a subscription model, in the conventional fee-for-service inpatient DRG mechanism, that would then serve as the baseline, right? And you would have a model that's carefully set up and where there's like a matched cohort between the experimental group versus those patients who are receiving care that's being paid for through kind of ordinary Medicare payment systems. And it would be more on the tail end when there's an evaluation that's conducted, where we would be able to make some statements or some observations regarding whether it's length of stay, which, as you mentioned, is a little bit easier to measure, but also perhaps ER visits, visits to the primary care physician, or unexpected inpatient hospitalization or admission, and then being able to then look at the associated ICD-10 codes, right, that are associated with those visits, would give us some idea in terms of what exactly was driving that visit to the hospital or to the ER or to the doctor.
Okay, thank you. If we have any more, Michael, you've come online there. And went off. I'm going to see if we have any other questions. Kind of last call for questions. Otherwise, we're going to let Dr. Shaw go on with his day. Who either has a fake background or it looks lovely where he is.
Oh, thank you.
All right. If there's no other questions, Dr. Shaw, thank you very much. Really appreciate it.
Thank you again for the opportunity. Appreciate the invitation.
Yeah. All right. Thanks.
Thank you.
Take care.
Thank you.
Okay, Joanne, I'm going to turn it back to you temporarily. We finished a little bit early.
We did finish a bit early. Should we take 15 now and then come back and start close? Is that
Sure.
okay for everyone?
And should we log off and then log back on? Is that the best way to do it, or just?
I think Layla that is the best way to do it, correct?
Yes, it is.
Okay.
Log out and then log back on.
So everybody log off and log back in at 5 after the hour?
That sounds great. That sounds good to me.
Okay, at 5 after the hour. All right.
Thanks
everyone.
everybody. Bye-bye.